So we'll move now to our next speaker, who is also based in California. We have the great pleasure to have with us Professor Richard Finn, who is a medical oncologist in gastroenterology. He's based in UCLA. As you can see, nice weather. Hi, Richard. And he's a principal investigator on many important key trials in the field, has published extensively on hepatocellular carcinoma, and I think he's really the best speaker who could educate us on phase 2, ongoing trials in hepatocellular carcinoma in phase 2. Thank you very much, Richard, to be with us today.
Do you hear me? Do you hear me?
Yes, we hear you now.
Okay. It's a very nice introduction. My background is fake, but the weather is very nice. I suspect a little warmer than where you are. But that's a very nice introduction. I appreciate that. Let me share my screen. I'm happy to be with you today, although next time we'll have to be in person. Let me see here. So I've broadened the topic a little bit to just drugs in development. This is a huge topic. I think in the context of what's going on in the liver cancer space. Liver cancer, I always used to say, was an orphan disease. When I started in liver cancer after my fellowship in 2003, there really was nothing going on. And the advance of sorafenib in 2008 was important because it showed that we can get a drug approved in liver cancer. Liver cancer was always looked at as a graveyard for drug development because patients were sick, patients had their cirrhotic livers and comorbidities, were high risk for toxicity. It was very hard to show that a drug would improve outcomes. And sorafenib, again, was important for patients because it provided a survival benefit, but it also was important for industry to see that in a well-designed study, you could get drugs approved. And I give a lot of credit to Joseph Yave and Jordi Bruges for opening up that spigot, so to speak, for drug development in liver cancer. However, as you know, for about 10 years, that spigot, was pouring out things in a clinical development. Things were flowing out, but nothing succeeded. And that changed in 2017 with the approval of lenvatinib for non-inferiority. Actually, before that, regorafenib was approved, actually, slightly before len in frontline, but rego in second line. And then we had a flurry of new molecules, but clearly the biggest practice-changing thing in liver cancer was the development of IO, immuno-oncology. And I'm sure you've heard about that during the day. And, now I would argue that liver cancer does mimic other cancers. And that is to say that as things are moving through development in melanoma and kidney cancer and lung cancer, et cetera, many of them are also flowing into the liver cancer space in early phase studies for safety and then efficacy. But also, cancer medicine is advancing, and the advance has been from chemotherapy to targeted therapy to immunotherapy to now cellular-based therapy, and really the next generation, I think, will be antibody drug conjugates, and all of those are being pursued in liver cancer, and I'll touch on that. These are my disclosures. Let me just minimize that. So as I commented, there's been a lot of advances in liver cancer, really changing the landscape. And if we look at frontline, you see all the data here, and I think you've probably had lectures on this during the day. These are global approvals, though we also have other positive studies. The way I like to think about drug development or options are TKIs for patients who can't get IO. And then there's the IO-VEGF combinations, atezo-bev. Then there's IO-IO, such as durvalumab, and maybe we will soon see the results of ipi-nivo, ipilimumab, and nivolumab. So that's CTLA-4 and and PD-L1 or PD-1 inhibition. And then also recently we have positive data, but no approvals, at least not in the West, of rivasirnib and camrelizumab. And this is a TKI, VEGF TKI, and IO. So we have three groups that have really set up unmet needs in liver cancer. One of them, I would argue, is how do we determine which is the best regimen for any individual patient based on either biomarkers or clinical characteristics. Right now, we don't have either to tell us which patient benefits from which approach. But what do we do next? I mean, clearly, the benchmark has been set very high now, or higher, with IMbrave 150 reading out with median survival in this clinical study population of 19 months. How are we going to beat that? There's a whole debate that we could have on endpoints for moving forward in liver cancer. And I know Riccardo Lencioni spoke on the Emerald study probably earlier, and that improved PFS in intermediate disease. But is that the most important endpoint? And that needs to be an area of debate. But also in advanced disease, for moving forward in the next generation of phase 3 studies, a primary endpoint to beat a hazard ratio of 0.59 versus sorafenib, to get that type of data versus atezo-bev will be very hard to do. And we'll have to select those regimens carefully. Similarly, some strategies might be used to durvalumab as a control arm moving forward, as its magnitude of benefit was not as great, but I think some studies will be faulted if that is the control arm. And as I commented, the other unmet need is what do we do after IO, right? Let's be honest. We have a lot of drugs available, highlighted here. In the US, we still have single agent Pembro available. Ipi-Nivo still has accelerated approval in second line. But all of these drugs were only studied after sorafenib, right? They were not studied after lenvatinib, and they certainly were not studied in a high level evidence way after IO, let alone doublet IO, IO doublets. And, you know, an opportunity for approvals will be after frontline IO. We use all the drugs here because we know they are anti-cancer drugs. We know they are anti-liver cancer drugs. They have been proven to slow progression. They've been proven to improve survival versus placebo. And just like in other areas of cancer medicine, when we have a new drug approved in frontline, we don't necessarily ignore all the drugs that were developed prior to that. One of the best examples, because of so many approvals, is I like to say in breast cancer, you know, the approval of new drugs such as cyclin-dependent kinase inhibitors in frontline doesn't mean we ignore the other 8 or 9 drugs that have been used in second, third, fourth, and fifth line and beyond. We just don't have high level. In fact, you know, in clinical practice, outside of a trial, I often use Ipi-Nivo after frontline atezo-bev, and then, you know, we have seen responses. You know, and I think one of the unmet needs and what we want to see in the next generation of drugs is objective responses. We've gotten greedy because we know that if you respond to IO, your prognosis is much better than if you have progression. How do we capture objective responses after IO, or how do we improve responses in frontline IO? These are all very important unmet needs for us moving forward, and will take, you know, some significant breakthroughs, I would argue, to continue to elevate the bar. And what is the next big hit is not necessarily obvious. I think we're in for a little period of time of quiet approval, other than the studies that are already launched, such as an early stage disease with TACE or with post-resection. There's still several studies we're waiting for, but otherwise, I think we're in for a little quiet time. And so some of the unmet needs. And I introduced this concept because it also affects the next phase of drug development. Patient selection. Can we narrow that down based on clinical characteristics or a biomarker-driven approach? And, there was a story put forward a few years back now about patients with non-alcoholic steatohepatitis, NASH, not being as responsive to IO. And I think as a laboratory study, that was very interesting, and it set up the idea of IO having immunosuppressive environment, or NASH having an immunosuppressive environment that prevents IO from working. But when we look at the clinical studies, really, I don't think that data holds up. And keep in mind, with all fairness, clinical studies look at non-viral as a group, whereas the Pfister study that was in Nature looked at NASH specifically in their models. So we might need to refine that. And some of the clinical studies moving forward are stratifying by etiology, which might help answer that question. But other than that, we don't have very good clinical markers. And I shouldn't even say other than that, because that's a hypothesis. Right now, typically we treat all etiologies the same. And then a biomarker approach. I commented that we have IO-IO, IO-TKI, IO-VEGF. And could we develop a biomarker suite that tells us, the patient in front of us, which approach to use? Now, when we're driving new drug development, I think there's some concepts to keep in mind. One is something driven by preclinical data that suggests a mechanism of action that is associated with synergy, right? And that might be that we understand acquired resistance that is driven by a certain genetic alteration, and then developing a drug to target that alteration and move things forward through clinical development in somewhat of a rational way. Historical drug development in oncology has not done that. It's been very empiric. And sometimes empiric medicine works, sometimes it does not. Probably in cancer drug development, more often it does not work. And this idea that we just throw drugs at the wall and see what sticks may not be the best way to move forward. But at the same time, we need to move forward. We need to try. Just because we don't understand something completely does not mean it's not unreasonable to take a look for a signal in the clinic, and then move that further along. And then ultimately, we need new targets in liver cancer. Right now, the targets we're looking at, as I showed before, most of the drugs that are approved in advanced liver cancer are VEGF targeted drugs or IO targeted drugs, PD-1 to be specific. And what are new targets that are HCC specific that might be of interest? I see Dr. Gale entered. Hello, Peter. So there's been a lot of work on molecular profiling in liver cancer. And this review, led by Joseph Beauvais, looks at the fact that we understand that liver cancer is not one disease. We commented on the viral, non-viral, but it can be further broken up into very distinct molecular subgroups. And within those subgroups, identifying potential targets for treatment. But with that being said, none of these molecular groups have been applied to clinical practice. We don't use any biomarkers in selecting patients, and even in early drug development, we're not using these type of categorizations of tumors to choose patients. This is very different than other tumor types. And again, I think breast cancer stands out as a paradigm for all of cancer medicine, where molecular subtyping has distinguished different subgroups of the disease that have impacted treatment decisions. And even now, in early stage breast cancer, molecular phenotyping helps us decide whether or not we give adjuvant chemotherapy or not. And certainly this approach, one day will affect liver cancer. And I would argue that that will happen when these type of tests become commercialized, or when they have some impact on drug choices. So one of the interesting targets that I think is somewhat, there's still some debate about its importance, is beta-catenin. Beta-catenin mutations have been identified in liver cancer as one of the most common mutations that occur, and that was on the prior slide. And several studies have highlighted, and two of them are here, but since then there's been several others that have proposed that beta-catenin activating mutations are a way for liver cancer to escape immunotherapy. There was this study from Sloan on the right that actually just looked at, outcomes for patients treated in the clinic, and then comparing that to their next generation data on all these samples. The cancer discovery paper on the left was a little more basic science and translational that worked out some mechanistic data, and then again looked at clinical cohorts to show that these activating mutations might be associated with resistance to IO. Now, in the Checkmate 459 study, which was a very large study of single agent IO, in this case nivolumab versus sorafenib, a very clean study, and they required tissue on everybody. And that left us with, I think 700 to 800 patient samples to look at. And again, the tissue was baseline. The tissue was not used to stratify patients. It was all looked at retrospectively to the clinical data, which was collected prospectively. And, this study really did not show any significant difference in outcomes based on beta-catenin mutations or other alterations for patients receiving nivolumab. Overall survival was not significantly different. You could argue that there was a trend and maybe it just didn't reach statistical power. But needless to say, this study did not answer the question that patients with mutations necessarily do worse than those who are wild type. With that being said, there are drugs in development against this pathway. This pathway has been a challenge because, unlike other targets like the VEGF receptor, simple TKI inhibitors are difficult to develop. And depending on the alteration, sometimes there's a knockout, which leads to more activation. And how you target something that is knocked out can be a challenge. There were, and maybe I suspect there still are, some antisense approaches. This molecule from ASI, E7386, is proposed to target the beta-catenin pathway by interrupting this interaction that occurs just at the level of transcription, or the transcription activation of beta-catenin, and has shown preclinically to modulate, proliferation, angiogenesis, and subsequently the immune microenvironment. And it has been proposed that there's several mechanisms of action to this drug, which can not only increase activity in combination with lenvatinib, but also overcome resistance to IO. And there's currently 2 clinical trials ongoing with this compound, one in combination with pembrolizumab after prior IO, and one in combination with lenvatinib for patients who had prior IO, in which case lenvatinib might be a reasonable second-line option, or for patients who aren't candidates for IO in the frontline setting. And here you see some of the preclinical data that's been put forward. And they have shown that this is not only unique to beta-catenin mutants, but also in wild-type patients. And here you can see that It has potent anti-angiogenic activity that seems to be potentially synergistic with lenvatinib, which also is a potent VEGF receptor inhibitor. And we've seen that with VEGF inhibition, we can see modification of the immune microenvironment and potential synergy also with IO. So I also commented on this idea that personally, and I think many others would agree, that we don't know what the next frontline regimen is going to be, and that there has to be some empiric approach to that. And the Morpheus study was a study launched by Roche just about the time of atezolizumab's approval. And this study was designed in a novel approach to explore triplets in combination with atezolizumab to look for a signal of activity. And the idea here was that there are many different agents that have been proposed to work in combination with IO. Atezolizumab is a standard of care frontline with a benchmark objective response rate of about 30%. And the question was, how do we improve on that 30%? And it's not clear what the answer is. So this was a very adaptive study where various agents are being plugged in to the program, and it is randomized, though no stratification factors are used. And when I say randomized, some patients will get atezolizumab as the control arm as a benchmark, and then patients are otherwise randomized to one of the triplets. One of the first drugs to go in was tiragolumab. Tira is an anti-TIGIT monoclonal antibody. And like PD-1, it is a checkpoint that regulates the immune system. And increased activity here can lead to an immunosuppressive environment. And the idea was that in combination with atezolizumab, we might see more activity than in atezolizumab alone. And I presented these data at ASCO last year. And here you see the various areas where TIGIT plays a role, not only in the lymph node space, but also in the direct tumor microenvironment, in playing a role in combination with PD-1 in its regulatory environment and down-regulating the immune response. And if we could negate that down-regulated immune response, then we could get immune activation. And this was the basic study design. The primary endpoint really is objective response rate. And with tiragolumab, we had 40 patients in the treatment arm and 18 patients in the atezolizumab arm. And, in red, you see the objective response rate with the triplet was 42%, 42.5%. Atezolizumab only provided an objective response rate of 11% in this arm of the study, or in this study. There were only 18 patients here, and as we've added more patients here, this objective response rate has started to rise. And I don't want to overstate 42.5% because that's also only in 40 patients. But, I think personally, I've always felt a signal for activity to move a drug forward from phase 1B or 2 into a phase 3 study would be a minimum of 40%, given we know that will fall in a larger phase 3 study. And you can see here that these were very durable responses here on my right in red. These tended to happen very quickly, median time of 2.5 months, and the median duration of response still has not been reached. And here we're looking at PFS in this study. So, we put in the middle here in dark blue the PFS from IMbrave 150, where we had 7 months PFS as the benchmark. In the bottom line, you see how atezolizumab has performed in this study, 4.2 months. And you can see with the triplet in red, PFS was 11 months, which is, again, supporting this signal that potentially adding tiragolumab to atezolizumab will improve outcomes. And importantly, we really didn't increase toxicity significantly. You know, the grade 3, 4 adverse events were even better in tiragolumab. Grade 5 events were similar, but those were not felt to be treatment related, uncommon. And having discontinuations were fairly uncommon as well. And the need for steroids was similar with the control arm. We did see more pruritus with the addition of tiragolumab, which was an interesting observation, and that probably is something that we need to be proactive on and managing. But typically, more serious side effects from what we see with atezobev were not seen. And you can see patients were on tira and atezobev longer than atezobev alone. And this has now moved into phase 3. The study is accruing. It's, I think, the first new generation phase 3 study in liver cancer, and is tira and atezobev versus atezobev and placebo, with the primary endpoint of PFS and OS. And we look forward to validating the observation from the early phase study. With that being said, cellular therapies are now making a play in liver cancer. CAR T or other T cell targeted approaches are being used, and they're looking at targets that have actually been around in liver cancer for a while. When I say been around, is we've known that these proteins are differentially expressed in liver cancer as compared to normal liver, such as glypican-3. That was actually pursued as a target with naked antibodies some time ago. But both CAR T and engineered T cell receptor therapies are being looked at in liver cancer. These therapies have had a big impact in hematology in some lymphomas, but to be honest, in solid tumors, they have not really succeeded that much. There are case reports of dramatic responses with these in liver cancer, but keep in mind, this is a challenge in liver cancer. These patients all need a conditioning regimen with chemotherapy, a myelosuppressive approach, which in a cirrhotic group of patients, might be difficult. A lot of these are HLA selected as well, which makes it challenging. This study looked at one of the T cell receptor approaches against alpha fetoprotein, right? So AFP also cancers, a circulating protein, which I think is one of the challenges we had in this study. We did see some response, but most of the patients did not respond. And this study actually has read out, and I'll show you the data here. And so this required patients to undergo lymphodepletion while first they had to have their lymphocytes engineered, collected with leukapheresis. Then they got chemotherapy prior to their T cell infusion, and then they were hospitalized watching for toxicity. And this is the basic idea here. And this was required to have a specific HLA to target AFP that is being presented in an antigen in an MHC complex. And, there was one complete response, a small study. There were several patients that had stable disease. Some patients who had disease control that didn't reach 30%. That probably just is not high enough to move this further, but requires some refining, whether it was the dose of T cells infused or better measurement of selection of the target. But we did not see a lot of toxicity, which I think was important. And I commented about anti-drug conjugates as the next phase in cancer drug development. There are several ADCs that are currently approved in cancer medicine, in other diseases. The idea here is to take an antibody and add a very highly toxic payload. And most of these drugs are chemotherapy drugs, cytotoxics, that cannot be given systemically because they're just too toxic. But by linking them to an antibody, we can deliver them very safely to a cancer cell. Many of them do have some bone marrow suppression or other idiosyncratic effects. Again, in breast cancer, HER2 amplification has been a target for these drugs, and several of these drugs have been approved and show significant activity. For example, trastuzumab deruxtecan has been associated with interstitial lung disease. Again, something somewhat idiosyncratic. That drug is also now, I think, being pursued and has positive data in gastric cancer, HER2-amplified gastric cancer. And the beauty of this approach is that it's not requiring an oncogene or an addiction for activity. The basic idea is that if you identify any protein on a cell surface that can be internalized and brought into the lysosome, where then the drug can be released, and it can have an effect by killing the cell that that uptakes the drug, but also as that cell dies, toxin can be released in the local area and have what's called a bystander effect. And in liver cancer, there are targets, again, glypican-3 being pursued among others, for an ADC type of approach. And always toxicity will be an important question. How well differentially expressed is this protein in a cancer cell versus a normal cell? And here is an example of several drugs in development against specific targets in the hopes that this target is differentially expressed enough between cancer cells and normal liver. Again, this is different than other diseases where, the organ toxicity is not going to be impacted as much by having a cirrhotic liver. Again, there can be some bone marrow suppression still from toxin release. And again, these drugs will have to be approached fairly carefully. And, in closing, I just want to comment, we know there's several phase 3 studies looking at TACE in combination with IO, and I think Ricardo touched probably again on these. But certainly in the United States, Y90 has largely replaced TACE for intermediate disease. It's had a very rapid uptake. Globally, this is not the case, which is why all the phase 3 studies have been looking at this approach with TACE, right? Because Y90 is not used globally. This study here, one of the recent publications looking at Y90 and IO, actually shows a fair amount of activity, and 60% of these patients had portal vein invasion, macrovascular invasion. Most of them were Barcelona C, and they show this very significant response rate and disease control rate, about 80% objective response rate, median OS that has not been reached, and a median PFS of about 7 months. Now, how we move this into a phase 3 study or beyond will take some thinking. Again, you could argue that this PFS of 7 months is not much different than what we saw with atezo-bev, right? In IMbrave 150, it was 7 months. So will we be looking at Y90 or LRT and systemic treatment versus systemic treatment alone? These are questions and things that we'll look forward to in the future. And this slide, I think, got out of place, but this is our internal efforts to identify targets in liver cancer. We have a translational lab that's very interested in drug development, and one approach has been to go through the TCGA, for example, and identify differentially expressed proteins, at least by expression data, which then needs to be confirmed that the protein is on the cell surface, that it's internalized. But we have identified some potential targets for ADC development based on this approach. And again, sorry that was out of place, but coming back to local disease, this idea of different approaches to destroy tumors is moving forward. This company Novocure has developed an approach, which, to be 100% honest, I thought was kind of silly when I first heard about it, but has actually positive phase 3 data in glioblastoma. And this is the idea that, patients actually wear a device, pads. Right now it's on the brain, for example, that emit these electronic fields, alternating electric currents that actually disrupt DNA and, maybe have other non-direct effects, such as affecting the immune system, and is globally approved frontline for GBM. There was a positive study in lung cancer last year, although I understand some people have complained about the control arm. They are waiting for data in pancreatic cancer. And there's been some early studies in liver cancer, and whether or not it moves ahead, I think will depend on some of the results from other diseases. So as I commented, we've seen an evolution in cancer therapies. We're not developing any more cytotoxics in liver cancer or any oncology. New chemotherapies are uncommon. I think largely, with few exceptions, and there is some overlap, we've really gone through this phase of targeted therapies, TKIs, naked antibodies, which led into these immunotherapies, and we still have some under development. But I think we can all be honest that other than CTLA-4 and PD-1, PD-L1, we haven't really hit on a lot of new antibody-directed targets. But again, tiragolumab looks interesting. And now we're in this age of cellular therapies and anti-drug conjugates, which will be applied to liver cancer. So IO has established a new standard of care, but has left us with unmet needs moving forward. And we're looking for new combinations, new targets, and new approaches. So I'll stop there. I always like to thank my colleagues at UCLA who have been so supportive of me and helped me really succeed in this space. Thank you very much for having me.
Thank you very much. It was a very inspiring talk, really showing us the new possibilities which are coming in the field of hepatocellular carcinoma. Do we have any question in the room? Yes. Can you just give a microphone to Dr. Radu? Pompilia.
My name is Pompilia Radu. Thank you very much for the presentation. I would have two questions, in fact. Where do you think that is the place of the liver biopsy in the treatment of the patients with immunotherapy? And do you think we should do during the course of immunotherapy, especially in those with progressive disease?
So, it's an excellent question. And obviously the field has moved, from this area. Well, you don't need a biopsy because we can make the diagnosis non-invasively based on imaging, to one that maybe we should be biopsying more patients. But let's be honest. In clinical practice, the biopsy doesn't teach us that much. I don't know if you tend to send something like Foundation Medicine or NGS on patients. There aren't really any mutations that are common in liver cancer that are druggable. NTRK being reported as a potential targetable alteration, regardless of histology, but really very uncommon. And it really has no clinical implications for our patient now, a biopsy. In the context of research, I think it's very important, right? And many studies, at least early phase, do require biopsies. When we move to phase 3, often it's optional because it can slow down accrual. And I know my colleagues, and we go back and forth and debate, do you require a biopsy on patients when they enroll, at progression? Those type of questions, I think, are very important in early stage development, to better understand what the drugs are doing. It can be hard in a phase 3 study, as important as it is. With that being said, Checkmate 459 required tissue on everybody, and everybody had it done, and we have hundreds of samples to look at. Unfortunately, it was a negative study. So it's the interest in doing too much biomarker work is not high. But one last comment, the common theme in all these molecular studies that have been done has been an inflamed, infiltrated, T-cell infiltrated, lymphocyte infiltrated tumor at baseline is associated with a better response to IO. And has been validated prospectively. But again, unless someone commercializes that, and if there's an entrepreneur in the room, I'd be glad to work with you on that, right? An assay that has been validated, it's going to be hard to have a very high uptake, I think. But I think it is important for research.
And the second question would be concerning the timing of SIRT combined with immunotherapy. This combination would be time when to do first the SIRT and after that the immunotherapy, to start with immunotherapy and after that SIRT?
I'm missing that first word, silt, or what's the,
And
what's,
immunotherapy, IO.
but what's the first?
The
What's
third,
radioembolization.
radiotherapy, selective internal
Oh,
radiotherapy.
SIRT.
Yes.
Okay, selective internal radiotherapy. I would think probably doing it maybe a dose or two before, and then continuing it after would probably be a good approach. And I bring that up because, you know, we've seen in melanoma in the surgical space, right? There was a study published last year in New England Journal of Medicine. My colleague Tony Rebus at UCLA was senior author on that, that showed in melanoma, if you give 3 or 4 doses of IO before surgery and then 2 after, it's better than giving everything adjuvantly after surgery. And part of that is exposing the immune system to any antigens that exist before the tumor is removed. With SIRT, you know, some people would argue that complete radioembolization can lead to a complete path response, like surgical lobectomy. And again, that might release new antigens as well. So maybe having the immune system primed beforehand would be important. So maybe a dose or 2 before. Again, that's hypothetical.
Interesting answer. Thank you very much. Thank you, Richard, for being with us today.